and liver cancer, focusing not just on gastroenterologists, but also on cardiologists, endocrinologists, and most especially primary care providers. Doctors Munteanu and Quiambao will discuss with us the role that LiverFast can play as we update our management practices in clinic. We hope you enjoy the next hour and feel free to ask questions at the end of the talk.
Good evening, everyone. So thank you for having us this evening. So just some reminders for some house rules. So please keep your microphone muted and please do not turn on your camera. So if you have any questions, please type them in the chat. So as we proceed, let me introduce first our moderator for this evening, Dr. Ronald Quiambao. Dr. Ron was awarded his medical degree from De La Salle University. So he's a doctor of medicine licensed to practice in the Philippines. He has a master's degree in business administration and licensed registered nurse. He has a solid background in clinical trials, regulatory, market research, and medical marketing. Dr. Ron is currently conducting the LIVERFASt FDA registration clinical trial in the United States, intended to validate LiverFast versus liver biopsy in the multi-site cohort, including the most prestigious top-level hepatology centers across the U.S. territory. So to introduce our speaker for this evening, Dr. Ronald Quiambao.
Thank you, Lloyd, and good evening to everyone. So thank you again for inviting us for this webinar from the Hepatology Society of the Philippines. So we are very fortunate today that we have our speaker from Paris, France. Her name is Dr. Mona Munteanu, and she was awarded a medical degree from the University of Medicine and Pharmacy at the Carol Davila, Bucharest, Romania, and was USMLE certified in the United States. She also has a background both in clinical hepatology and clinical research, where she obtained
Doctor, I think you're mute po.
Oh, I just unmuted. And okay, sorry. Do you want me to start? Okay. Okay. So again, our speaker, Dr. Mona Munteanu, was awarded her medical degree from the University of Medicine and Pharmacy at the Carol Davila in Bucharest, Romania, and was USMLE certified in the United States. She has a background both in clinical hepatology and clinical research, where she obtained her PhD in physiology, physiopathology, and therapeutics from Sorbonne University in Paris, France. She has published more than 100 articles in peer-reviewed journals on non-invasive liver diagnostics and more than 150 abstracts accepted in national as well as international liver meetings for almost 20 years. Dr. Mona is also involved in several teaching programs in more than 20 countries, mainly focusing on hepatology and non-invasive liver diagnostics. So without further ado, let me introduce our guest speaker for today, Dr. Mona Munteanu. Mona?
Good evening, everyone. Thank you so much, Ronald, for introducing me. And I want to thank also our hosts to invite us and to thank everyone for the interest in our technology. I will be very happy to present you our main test, first-line screening test called LiverFast as a prognostication enrichment biomarker for long-term hard outcomes prediction in NAFLD patients. Next one, please. So our core of technology, it's non-invasive. It's based on algorithmic diagnostics, detecting organ lesions caused by metabolic or chronic viral diseases. We have 4 main applications generally, and also for the liver, as for other organs. We are looking for screening biomarkers that are providing risk stratification, optimize the cost, and can ensure preventive measures. For staging biomarker for diagnosis, early detection of a lesion like fibrosis until late detection, and precision diagnosis to optimize the patient's management and outcome. Because all our biomarkers are prognostic enrichment biomarkers that were validated against hard outcomes and are predicting overall survival and liver-related survival for the liver fibrosis biomarkers. Our markers are intended as well for monitoring of disease progression or regression, and this is very important in chronic liver diseases where there is a treatment and that could be adapted according to the response to treatment. We are looking for fibrosis across multiple organs. We have biomarkers for kidney, for heart, but also for other organs in the pipeline. However, our main core technology is intended to the diagnosis of the liver lesions. Next one. So we are combining generally very simple and ubiquitous biomarkers along serum biomarkers along with anthropometrics like BMI, like age and gender, some risk factors in some of the predictive biomarkers that we have. Our technology, it's using AI algorithms, neural networks, and we provide reports the risk lesion for some of the biomarkers or the staging, the quantitative staging of the lesion, as for example for the LIVERFASt test. The main example with LIVERFASt, it's related to the fact that in chronic liver disease, even if there are now some established standards of care, the problem is the very low detection level. There is a big unmet need to screen the patients at risk NASH subjects, and to identify those that are at higher risk for severe NASH. And as Dr. Stephen Harrison said, the NASH accounts about 1 in 5 or 1 in 4 of all NAFLD patients and can be challenging to diagnose. And LIVERFASt uniquely gives us an opportunity to identify these patients and direct them to appropriate care that may help prevent progression of their disease. Next slide, please. So our partners are across, are worldwide distributed, and as you can see, we have a privileged situation in Asia, in Asian countries, and we have more than 100,000 patients diagnosed in different healthcare systems. We have partner laboratories that are doing the biomarkers needed for our technology in standardized and pre-analytical and analytical conditions. And we are working with a lot of medical centers, sometimes with pharmacies, with foundations, and we have 100% customer retention. Next slide, please. So, as you know, and this is why you are attending this webinar, this is a global silent pandemic driven by the metabolic syndrome, which is a defective inter-organ communication by liver, adipose tissue, muscle, pancreas, brain, and so on. And the problem is this pandemic is driven by two main factors, which are diabetes and obesity, and clinically complicated obesity as well, which is an identified risk factor for liver fibrosis. The main organs that are hit by this are the heart, of course, the liver, and the kidney as well. Very few patients are diagnosed, and too many are underdiagnosed. And moreover, among those that are screened for having a diagnosis, for inclusion in pharmaceutical trials, the screening failure rate is up to 70% using the standard of care that is actually available. So this is why the morbid mortality caused by this disease is very high, because it causes progressive failure and cancer of multiple organs. And even if the liver cancer became one of the main causes of liver transplantation in NASH patients, we have to keep in mind that these patients are dying also from cardiovascular major acute events, and also they are dying of oncological extra liver causes. So for sure, this is a very complex disease, and we want to focus on the early diagnosis of the liver lesions related to this pathology. Next slide. So the prevalence of diabetes in Philippines, it's very high, and it is estimated that 1 in 5 Filipinos are discovered to be diabetic or in a pre-diabetes stage of the disease, and 7 million people are estimated to have diabetes. These are diagnosed, these are numbers from 2019, but also 4.4% of adults are estimated to be undiagnosed, while more than 7 million, 9 million of people have prediabetes, and 14% of adults are considered to have prediabetes. And so nothing is done for them, and there is no screening. I mean, on a national scale, even in countries with high prevalences like United States, there are some initiatives coming from foundations, but not coming from healthcare authorities. So the prevalence of diabetes in Philippines is increasing every year. And probably this will reach numbers that are equivalent to other countries with high prevalence. Next slide. For example, in Asia, it's estimated now to be 27.4%, similar to Europe, to North America. A little bit lower than the Middle East and South America. The problem is not only diabetes and obesity, but the other factor related to this risk is age. And we know that 20% of the general populations, it's the estimated prevalence of NAFLD. And of course, this prevalence, it is higher among other subgroups with higher risk. It varies across ethnicities, and it's always higher in urban than in rural populations, and always more prevalent in males and in aged subjects. And this is a risk that it's already known not only for NAFLD, but also for fibrosis, because male gender and age are two main risk factors for liver fibrosis. Next stage. Next slide. Next slide, please. The NAFLD prevalence in Asian studies. There are several studies that are now well known and you know very well, that were done in Asia, and the prevalence of NAFLD was estimated to be 29.6%, and also the prevalence of lean NAFLD 11.8%, with the highest prevalence in Korea. Next slide. The global epidemiology related to of NAFLD-related HCC, hepatocellular carcinoma. You can see there are some red zones with extremely high prevalence of HCC, mainly related to diabetes and obesity. And if we look in Philippine studies, this is estimated, this is variable, the estimation, between 5 and 25% among patients having NASH cirrhosis. Next slide, please. So we know very well that the NAFLD it's a progressive disease. It's a complex disease requiring 3 different lesions to have a diagnosis of NAFLD, from simple fatty liver, more than 5%, estimated at more than 5% of the liver, and followed by inflammation and scarring, by cirrhosis, severe fibrosis with cirrhosis, and in some of the patients, occurrence of hepatocellular carcinoma. And this is why we created biomarkers that are adapted from early stage to late stage, not only to detect early lesions and to be able to help with preventive measures, but also for late staging stratification, and I will show you the results, providing the prognostication of the patient at long term, 3 years, 5 years, 10 years. Next slide, please. So we know now there are plenty of studies showing that patients with NAFLD have an increased all-cause mortality. The cardiovascular related mortality accounts for 1 in 4 deaths in people with NAFLD. And this is very interesting to know. But the cardiovascular, it's similar to the deaths coming from oncological extrahepatic oncological reasons, and the liver-related mortality is estimated to be around 13%. 13%. And if we look to the main causes of death that were estimated in NAFLD, again, cardiovascular on the first level in some US studies, 1 in 5 non-liver malignancy, 8% liver disease, 1% hepatocellular carcinoma. This is in US. Less than 1% are liver transplanted. There are some infections and other or unknown in about 1 in 4 patients in these big studies. Next slide. And when we look in Europe in studies, this is very interesting because this is a comparative study on the survival at 10 years in chronic liver diseases in the 4 most prevalent. And you can see the best survival it's now achieved in chronic hepatitis B, which is normal because we have since more than 10 years ago efficient oral drugs to repress the virus. In chronic hepatitis C, it's the second best survival. But if you look in pink, the survival in NAFLD, this is, it's very bad. And you can see 10 years after the baseline. So this means in patients over 50, the survival, it's a line graph, it's crossing the graph of the survival in LD, which is very poor because it's estimated to be 41% at 10 years. So this is a big problem, and probably in France, where there is a very cosmopolite population, the figures are similar with other geographical zones. Next slide, please. So this is why we created LIVERFASt. We wanted to complete NAFLD and NASH diagnosis for the three main lesions that are defining this disease: fibrosis, steatosis, and steatohepatitis inflammation. Next slide. So what is LIVERFASt? It's a non-invasive panel combining 10 biomarkers with anthropometrics. The biomarkers that we used are very simple and liver-related biomarkers, liver-specific biomarkers, 3 proteins: alpha-2 macroglobulin, apolipoprotein, and haptoglobin, and with liver enzymes, GGT, and the pigment, bilirubin. All have different roles. For example, for fibrosis, some of them are increasing with fibrosis, some of them are increasing early, some of them are increasing late, like bilirubin, and some of them are playing roles, multiple roles, like liver-specific proteins, apolipoprotein A1, that everyone knows as a transporter of the good cholesterol, HDL cholesterol. It's also related to hepatic growing factor and to interleukin 6. And when fibrosis is developing in the liver, apolipo A1 genes are repressed and the serum level is decreased in patients with fibrosis. This is just to provide you an example of how these biomarkers work. And this is why a patient can have all the biomarkers inside the normal range of a lab, and however, the score of fibrosis could indicate cirrhosis. So the normal range of the laboratory does not matter in the interpretation of the results. And for activity, ALT and AST, the other liver enzymes related more to cytolysis and to inflammation, they are presented. And as you can observe, they are not included in the fibrosis score to prevent variation of the fibrosis with fluctuations in ALT and AST. And this is a main advantage compared to other fibrosis biomarkers that are including these two enzymes like FIB4, because these populations that have fluctuations are prevented from fluctuations in the fibrosis estimation. And also the populations like patients with diabetes that normally have low ALT and AST and advanced fibrosis are prevented from having false negative results. For the steatosis score, the lipid panel is included as well, glucose determination as an indicator of diabetes, and weight and height as well. So on the right side, you can see the LIVERFASt panel, and you can see the 3 scores, quantitative scores that are displayed. There are scores from 0 to 1. Higher the score, more severe will be the disease. And also you can see a staging similar to liver biopsy, and similar to the SAF score of that it's a dedicated score for NAFLD that has an activity estimation based only on ballooning and lobular inflammation on liver biopsy. And this is a main advantage of the SAF score when creating biomarkers compared to the NASH CRN, where the activity score, the composite score, includes also steatosis. It's biased by steatosis. So our activity test, it's a pure activity score. It's not biased by steatosis. Steatosis, it's assessed separately. And as you can see on the result sheet, you can observe the biomarkers that are listed. Next slide, please. So again, LIVERFASt was validated and it's suitable for all use cases: for screening at-risk NASH patient, for diagnosis, these lesions, these 3 lesions, so for staging these 3 lesions quantitatively, for monitoring the regression or the progression. And this will be very interesting whenever the pharmaceutical options will be available in these patients with NASH. And for the prognostication, because the fibrosis score, it's related it's a prognostic enrichment biomarker. Higher the score, more severe will be the outcome of the patient. And this is what I will present you in the next slide. Next slide, please. So very rapidly, this is the study, the initial validation study against biopsy. And as you can see on the right side, in patients with obesity, LIVERFAST was able to stage LIVERFAST fibrosis, to stage fibrosis according to the clinical category. And as you can see, for example, in the first two categories where there is no NAFLD and only simple steatosis, so where there is no fibrosis, supposed presumed fibrosis, the negative predictive value is very high and there are no false positive results. And this is why we are promoting also LIVERFAST for screening purposes, because when you screen a population at risk, you need to not to release false positive results. And again, when you look in the disease population, those that are the most severe, that have diabetes and metabolic syndrome factors, they have significant in the middle. You can see the box plot in the middle. These patients, they will have the most, the highest score of fibrosis. The median value in these patients is significantly higher compared to other categories that have no diabetes or compared to controls. And if we look on the first box plot in yellow, you can see that LIVERFAST steatosis score is correlated with the number of metabolic factors. And the higher the number of metabolic factors, higher will be the median value of this score. So again, this is very interesting for assessing patients for the risk of steatosis. Next slide. So how about the comparative performances for cirrhosis in diabetic and non-diabetic patients? On the left, you can see that LIVERFAST fibrosis score has similar performances to the standard of care with vibration-controlled transient elastography by FibroScan and with FIB4. However, in diabetic patients, where the prevalence of cirrhosis is twice than the prevalence observed in non-diabetic patients, according to liver biopsy, in this population, this is an European study on 583 patients with biopsy and concomitant estimation with transient elastography, FIB4 and LIVERFAST. And you can observe that in diabetic patients, LIVERFAST had similar performances with FibroScan. However, both FibroScan and LIVERFAST outperform FIB4. And this is a very important result because probably FIB4 is overused in this population with diabetes and probably has a very high rate of false negative results. Next slide. And I wanted to put this slide just to explain that as in other studies, independent studies that were published in our validation study, we observed that ALT is decreasing with age range, while liver biopsy fibrosis stage is significantly increasing with age range. And the same was observed with LIVERFAST fibrosis score, that it's significantly increasing with each age range. And you can see the most severe patients are patients over 65, while these patients have ALT in normal ranges. So this is why we believe that ALT should not be used as a fibrosis biomarker, at least in patients with NAFLD. And there is a need of liver-specific fibrosis biomarkers that are true surrogates of liver biopsy to identify fibrosis in patients and to screen all the patients that are diabetic over 45 or 50. They are at risk even with normal liver enzymes. Next slide, please. And in the same study, we demonstrated that in patients without type 2 diabetes, ALT could be a driver of the progression to cirrhosis and to fibrosis. As you can see, patients with higher ALT in pink, in magenta, they have a faster transition to fibrosis than patients with normal ALT values. However, in type 2 diabetic patients, ALT plays no role. And again, probably because these patients with very severe fibrosis, they have normal ALT. Next slide, please. And how we compare with the standard of care, as I presented in the previous slides, we have the advantage to assess all the 3 lesions of the liver. FIB4, we know that has some drawbacks related to cutoffs, to age-impacted cutoffs, to the presence of liver enzymes in the formula algorithm of FIB4. VCTE also have some drawbacks related to obesity. And we know that we have a very high diagnostic performance for NASH when combining all the 3 biomarkers, which is 0.88. And this is similar to VCTE combined to, VCTE-FAST combined with CAP and ALT. Next slide, please. And this is a very interesting study showing that when the patients are follow-up monitored with LIVERFASt, we can observe significant regression of fibrosis in patients that have a significant and sustained improvement in ALT with more than 50% compared to baseline. And this is what is predicted, what is already known in the clinical literature. So this is very important because LIVERFASt, it's correlated with clinical endpoints and can be used for the long-term monitoring of NAFLD patients. Next slide. And you know the new definition of NAFLD is the MAFLD, and this is the advantage of this definition is to identify not those patients that have metabolic risk abnormalities, but those having obesity or being overweighted. And again, these are that the lower BMI it's required to identify the risk in Asian populations. And having type 2 diabetes, these are considered at risk from the beginning, and these patients are at risk MAFLD patients, even if their liver is still normal without steatosis and without fibrosis. They should be followed up and screened repeatedly every 2 or 3 years if they have two metabolic factors and diabetes, or if they don't have more than 2 metabolic factors and diabetes, and every 1 or 2 years if they have diabetes and metabolic factors. These are the new recommendations from AASLD released last week during the liver meeting. Next slide. So what about the prognostication value of LIVERFASt? This is a beautiful study that was conducted in more than 1,000 patients, 1,253 patients that have a baseline assessment with LIVERFASt, and they were followed up for a median time of 5 years. And it's very interesting because they had a baseline assessment of liver fibrosis with LIVERFASt, but also with liver stiffness measurement by FibroScan and FIB4. The profile of this cohort is the one that we know in tertiary centers with a median age about 56 years. Prevalence of females 56.5%, and the median BMI 31.3%. You can see that almost 59% of patients had a BMI higher than 30%, and 42% were diabetics. And you can see that the median values of liver enzymes are abnormal, are elevated. In terms of prevalences of fibrosis, you can see that according to LIVERFASt, there were 14% F4 stage, bridging fibrosis 13%, and the other one, so the 3/4 of the patients had F0, F1, and F2 fibrosis. Next slide. And if we look to the overall survival, we observed that the overall survival was decreased at 5 and 10 years according to the fibrosis stage with LIVERFASt. And as you can see, the lower survival, significantly lower compared to other stages, was observed in cirrhotic. And if you look to the causes of mortality and morbidity, these are the classical causes. And this is a very interesting study because it included also 14.3% of patients having hepatocellular carcinoma diagnosed, and 8.2% of them died because of this diagnosis. And this is a very interesting study. Next slide, showing that these biomarkers like LIVERFASt, like FIB4, like liver stiffness measurement, they could be included in clinical models along with other risk factors for fibrosis like age, gender, BMI, alcohol consumption, tobacco consumption. And whenever you include this in clinical models, you can even improve the prediction obtained with the biomarker alone. And this is true for all. For LIVERFASt, for the LIVERFASt score, you can see that the heraldcy index, which is a time-related, mortality, prediction of mortality performance for mortality, it's 0.78, and for liver-related mortality, it's 0.83, which is extremely high. Next slide. And the main advantage of LIVERFASt compared to other biomarkers, it was that the LIVERFASt fibrosis test independently predicts liver-related mortality and liver-related morbidity, including HCC, with the highest risk of liver-related mortality and morbidity, respectively, per additional point compared to the other two tests with FIB4 and FibroScan, which indirectly means that there is a higher accuracy per each stage of fibrosis with LIVERFASt compared to FIB4 or FibroScan. And when we look to the hazard ratio, this is 3.04 for predicting mortality, liver-related mortality, and 4.32 for predicting liver-related morbidity. And again, as I said, the median liver-related survival is significantly decreasing with LIVERFASt predicted fibrosis score. Next slide. In conclusion, in a time-dependent multivariable analysis conducted in more than 1,000 of NAFLD patients, LIVERFASt as well as transient elastography can predict global and liver-related mortality and morbidity, and can be used as prognostic endpoints in clinical trials and in clinical practice. LIVERFASt alone, as well as models including LIVERFASt, provided the best long-term prognostication for liver-related outcomes. Next slide, please. So how we can screen with LIVERFASt? The main question is, we want to know if the subject that is at risk NASH has simple steatosis, and if yes, how much fibrosis or NASH is there. And this is why we want to identify among those having steatosis, those having fibrotic NASH with F3, F4 stages, or non-fibrotic NASH F1, F2. Next slide. And so what we propose, and this is already validated, it's that, of course, the primary care contribute to this screening, and the patients should be addressed to radiologists or to hepatologists for confirmation. But however, LIVERFASt is a test that is identifying with high negative predictive value those patients that don't have advanced disease. So this can be retained at a primary care level. And only the patients that have suspicion of more advanced fibrosis or severe fibrosis could be referred to hepatologists, and of course to have a global integrative management of these patients. Next slide. I just want to provide several insights in special populations. We know that LIVERFASt reveals some liver cardiovascular interrelations in NASH. For example, incidental risk of major cardiovascular events are multiplied by 3 whenever there is advanced fibrosis. This is a study with liver biopsy showing this, that patients that have F2 or more, they have almost the cardiovascular risk multiplied by 3. And the risk for having major acute cardiovascular events is multiplied by 2 with important steatosis. So finally, we should not reassure all the patients having simple steatosis, because there is a cardiovascular risk remaining, even if there is not a immediate liver-related risk. And the second application of detecting the NAFLD risk is related to the COVID, and there are now many studies showing that there is an incremental increased risk of mortality with each fibrosis stage and with cirrhosis class. And steatosis could increase the risk of drug-induced liver injury during COVID therapies as well. And we had a very nice poster presented in AASLD last week with a screening tool which is a new screening tool, a little bit different from LIVERFASt because it's not quantifying NAFLD lesions, but it's identifying the risk. So this is very important because patients could be, we demonstrated that patients that are identified with NAFLD fibrosis, they have, with this screening tool, they have more severe COVID outcome in the next 2 weeks, including mortality and morbidity. Next slide, please. So in conclusion, LIVERFASt is a decisional aid for physician, which increases the patient's safety for screening and for staging, stratifies NASH fibrosis in either diabetic and non-diabetic, predicts mortality and morbidity, global and liver-related, simplifies the clinical workflows, and enables safe monitoring. And I think my colleagues added several slides to indicate you how to proceed with the lab. Next slide, please. Thank you for your attention. And if you have any question, of course, we will open the discussion now, but if you have clinical cases and questions about the result, you can send an email to our medical affairs team, and we will answer you immediately. And I think if you go to the next slide, my colleagues described the loop, how to prescribe a test. And the only thing that you should keep in mind and ask the patients to be fasting. This is not because the steatosis score that includes glucose and triglycerides, but also because whenever a patient is fasting, any biochemistry determination is of higher quality, analytical quality, because patients that are not fasting, this could interfere even with liver enzymes determinations. So generally, it's better to have the test done on in a fasting patient. Thank you for your attention again, and I think we can stop here and start take questions if we have.
Yeah, thank you, Dr. Mona, for that very nice presentation and very thorough explanation on LIVERFASt and the details, of course, well appreciated on the data that you presented. So for those who want to send their questions, you may do so in the chat box, or you can just unmute and then ask the question directly to our speaker, Dr. Mona. So just to start, I have several questions here at the chat box. Number one from Dr. Salvana Angela: is LIVERFASt validated for Asians?
Yes.
We have studies.
Yes, we have studies, of course, not only in NAFLD, but also in chronic viral hepatitis. and the diagnostic value is the one that we observed in other studies. So there is no difference between ethnicities. And first initial study when the algorithm, the AI-based algorithm were constructed, were done in Asian populations as well. So I think the answer is yes. And I see a second question, how long should patients fast? Fasting, of course, if a patient is not diabetic, normally they should fast over the night, you know, because for triglycerides, you need to have a fasting at least 9 hours. We know that fasting for glucose, it's 3 hours or 6 hours, but the problem with diabetic patients is they cannot be fasting. So what we can ask to diabetic patients is to eventually, if they can fast in the last 3 hours, and not to eat very fatty meals in the last, you know, in the evening if they are coming to take blood in the morning.
Thank you. And the other one, can you view the coming
Yes.
from Dr. Edhel's report? Yeah.
Yes, thank you for this question about false positive and false negative. This is a very important question in the non-invasive field. For the false positive, you are asking if there are false positive for fibrosis. There could be false positive for fibrosis for if a condition, a comorbidity could interfere with one of the biomarkers of fibrosis included in LIVERFASt. And the classical example is the one with a patient having hemolysis, chronic hemolysis, like a patient with thalassemia, even minor thalassemia, which is not quite frequent, but this exists. And this could falsely decrease the serum level of haptoglobin, for example, and could mimic fibrosis, because with fibrosis, serum haptoglobin level will decrease. This is an example, but this is less than 2% of all the results. And haptoglobin is just a biomarker among others, other 7 included for the fibrosis score. So the impact will not be so high. The impact probably is not significant, but this could lead to an increase, an artificial increase of the score. We use some security algorithms that are identifying those profiles that have only one biomarker indicating, for example, fibrosis, while the other one are not predicting fibrosis. So generally, if you have this kind of profile, a security algorithm will highlight this biomarker that it's inducing a risk of false positive result on the, you will have this indicated on the result sheet.
And there's
if you
a
have a
follow-up
suspicion,
question.
yeah.
Go ahead.
Just to add, if there is a suspicion of hemolysis with false positive result, the first thing you should do is, of course, to check the bilirubin, but also to do an electrophoresis of hemoglobin. So I see another question, more recently published using the same test as the older FibroTest validation studies. Do you want more? Yeah. So FibroTest is the pioneer test for fibrosis, and we are sharing some biomarkers from FibroTest with the LIVERFASt. FibroTest, it was a test that was constructed in patients with viral hepatitis, and it was thereafter validated in patients with NASH and NAFLD. And it's the cutoffs that are used for FibroTest are cutoffs that are adapted to viral hepatitis. And you know, there is a difference in bridging fibrosis defined with a METAVIR score for viral hepatitis and bridging fibrosis with NASH CRN or the SAF. It's not the same cutoff. Moreover, LIVERFASt was constructed using the SAF score that is dedicated to NASH. The next question, as a follow-up to the false positive in the case where there is hemolysis, do algorithms have safeguards for this, especially when, okay, yeah. In the setting of the CSPH, we are not able to to identify any condition, of course, but we can, a comorbidity could be presumed according to a profile of a biomarker, but we cannot identify any condition. But in any case, if you have suspicion of a false positive or a false negative result, you can send it to our team, to the medical affairs, or to any you have on the website a contact email as well, or you can contact locally your representative, and we will answer to your question, and we will discuss case by case.
Okay. Thank you, Mona, and
Thank you.
thank you, Doc. Yeah, thank you, Dr. Triton. Yeah, sure. Get in touch with me. Sorry. Yeah, but anyway. So, other questions? Please type in the chat box, or you may verbally unmute. You can unmute and verbally ask from our speaker. Anyone? So I have a question while the others are still maybe trying to create their questions for you. But on my part, since you have attended the recent American Association for the Study of Liver, how is the new guidelines coming up?
Yeah.
Is there a certain role that LIVERFASt would be more fitting now, knowing that I think Fib4, as we all know, is a non-proprietary test. However, the shortcomings of this test are now being visualized a lot from most doctors. So what do you think it will be the next steps on this?
So the American Association for the Study of the Liver will publish in several months the new guidelines, but they presented briefly, several slides and the new strategy. And there is a PCP pathway and the hepatologist pathway, gastroenterologist pathway in assessing the liver, in assessing the metabolic risk. And in the PCP pathway, they included as a first step Fib4, which is a little bit unfortunate, probably for diabetic patients. And as a second step in the PCP, there is a confirmatory study like VCTE and the serum biomarker. So like FibroScan and serum biomarkers. So there is place for serum biomarkers, and this is very interesting because they use the low cutoff for Fib4 to rule out advanced fibrosis, and all the patients that are in the indeterminate zone, so with scores of Fib4 higher than 1.3 or in the above the upper cutoff that rule in advanced fibrosis, they should be assessed for fibrosis using an imaging method like transient elastography and the serum biomarker, and they provided the example of the ELF test, which is FDA cleared, and probably this is the reason that they included in the pathway. And whenever the patient is coming, it's arriving in a tertiary center, those that are detected with advanced fibrosis, they indicated different pathways, including imaging like MRI, techniques for assessing, like MR elastography, for assessing further those cases that are unclear or discordant. And they indicated as well pathway of surveillance for cirrhotics, and they indicated that patients with minimal fibrosis should be reassessed periodically every 1 to 2 years if they are diabetic with minimal fibrosis and with less than 2 metabolic factors, and if they are diabetic with more than 2 metabolic factors, and every 2 or 3 years if they are not diabetic with less than 2 metabolic factors. So this is a new pathway indicated by AASLD. And I think probably in the final guidelines, clinical practice guidelines, they will expand their list of biomarkers that can be used in the.
Okay.
Yeah.
Yeah, thank you, Dr. Mona. So
Thank you.
do we still have enough time? Because I think one question more, if you have any, but if there's none,
We will
you
be. I see a comment. It would be good to get
Good to-
Southeast Asian validation studies. We will be
Yeah.
more than glad to do any study. So if you have any clinical research initiative, do not hesitate to contact me or Dr. Ronald, and we can discuss what we can do together. We'll
Yeah.
be more than glad to have Southeast Asian validation studies.
or if they have data sets or repository that is pending for us to
Again,
retrospective. Yeah.
the most rapid studies are those on data sets or biorepositories. We have a new screening tool, as I told you, and probably we can set up another meeting to present you a new screening tool that we have for NASH. And this will really enable the screenings at a general population level.
Okay. Thank you very much. So,
Thank you.
yep, I think I need to turn over to Lloyd for Dr.
Yes.
Wendell. Yeah.
So thank you, thank you, Dr. Quiambao, and thank you, Dr. Mona, for a very informative session. So for any further concerns, you may reach out to me. I'm sure most of our attendees here receives communication from me. So this is Lloyd again from Fibronostics. I head the commercial team for Asia Pacific. And now I have some final words from our Vice President, Dr. Wendell.
Thank you, everyone. Thank you so much for your attention.
Good evening. In behalf of the officers of the Hepatology Society of the Philippines, we would like to thank everyone for being present in this interesting webinar on non-invasive tests for evaluating patients with chronic liver disease, such as non-alcoholic fatty liver disease. I am sure we have learned important insights from our excellent speaker. We are grateful to her for sharing her expertise with us. And in behalf of the participants, we would like to thank Fibronostics for partnering with HSP in delivering relevant and up-to-date meetings. Lastly, we hope you will continue to support our academic activities. See you in November 25 for another meaningful webinar on HCC. Thank you and enjoy the rest of the evening.
Thank you very much.
Thank you, everyone.
So thank you, everyone. Have a nice evening and have a great weekend.
Bye-bye.
Thank you. Bye-bye.